Hey, welcome to the Go-To Physio podcast, the podcast that helps you get real-world results with real people while also helping you become the go-to therapist in your town. I hope you enjoy the show. Hey, welcome to episode 4 of the Go-To Physio podcast. My name is Dave O'Sullivan, and once again, thank you for joining me on this episode. Now, in the last episode, we talked a lot about why I believe the glute max, especially, it's only going to be as successful as the distal hamstring proximal gastro allow it to be. Now, we talked a lot about the foot at the floor, that we're looking for that co-contraction of the knee. So specifically the quads, the hamstring and the gastro, they're all doing their job so that we delay knee extension, so we don't allow the knee to snap back, or we don't allow the knee to sink as our foot hits the floor, we don't allow the knee to flex as the foot hits the floor. We keep that isometric contraction, which then allows the hip joint to do active work. If we got that knee to snap back, then obviously the knee will be doing the majority of the work. The hip would achieve extension, but a lot of that would be passive. So we want that hip joint to do work, not the knee joint. So to summarize the last episode, if we can delay knee extension, then we can let the hip do work. Whereas if knee extension happens too quickly, then the knee's going to do work, the hip's going to do less work. So if you want the glutes to fire in inverted commas, then a big part of that is going to be actually getting the knee to delay knee extension. Okay, a big part of delaying knee extension happens with the hamstring and the gastro, and specifically the proximal gastro-distal hamstring. Okay, distal hamstrings, and even more specifically the medial hamstrings, in my opinion, are probably the most important muscles for knee health. I think the glute is got a massive overreaction to it these days. I think the VMO has got a massive overreaction to it initially. Okay, I think a lot of people are getting obsessed with the glute and the VMO. Okay, you look at the muscle architecture. Okay, you see long tendons. Okay, in the hamstrings, designed for energy transference. Okay, again, that foot hits the floor. We want to take energy away, that ground reaction force as it comes up through the limb. We want to take it away from the knee. We want to send it up into the hip, so to speak. Okay, so the clinical test that we're going to want to use today, okay, is we're going to want to see, can our actual patient tolerate high levels of load through the hamstring and the gastro. Okay, so there's a very useful test that I use, and I'm going to say that again, but I'm going to go one step further. The test that we're going to use, we're going to see if the hamstring and gastro can tolerate high levels of load and allow the glute max to actually do work as well. Okay, so we see a lot of people these days, they're cueing push through the heels. When we appreciate why we want distal hamstring and proximal gastro to work, we can hopefully appreciate that if you just sit here now and you push through your heels, we're going to shift our weight to the back of the foot, which is going to initiate a dorsiflexion of the ankle, so to speak. Okay, now you push through the midfoot to forefoot. Okay, what's the first thing that's going to fire? Probably soleus, uniarticular, but you're also going to get gastro, and specifically we're going to get more proximal gastro. We're going to get a lot of distal hamstring. Okay, so a lot of people are doing glute bridges. They're saying push through the heels. I personally think that's not the most efficient way to do things. If you want to try walk and push through the heels as you walk, then I think you're going to look very, very funny. And this is where, again, we can look at this, and I get a lot of confidence from why I think I'm on the right track when I look at gait. The foot hits the floor, heel strike, that's fine. But the hip's in maximal hip flexion at that point of heel strike. As the weight starts to go from the heel onto midfoot, forefoot, the hip's extending. Okay, so the hip extends as the weight goes from the heel onto the midfoot, forefoot. You look at these guys these days that are saying everybody push through the heels, squeeze your glutes at the top. I know, don't get me wrong here. I've no problem with you pushing through the heels at the bottom of a squat. But what I don't want you to do is to be on your heels at the start of the squat before we've even descended. What I don't want you to do is to push to the heels and stay on the heels as you come up. Okay, so in a nutshell, I want everything to do its job. I want the weight to go from the midfoot to the heel, to the midfoot to the forefoot. Okay, I want you to challenge your base of support by challenging your weight distribution through your foot, and I want everything to do its job, not just one thing. And that reflects in all the rehab exercises that we implement here at the Pro Sport Academy. And if you want more information, you can go to my website, www.thegottophysio.com. You can pick up my book there. You can get my patient adherence checklist. You can see the accompanying videos that are going with this podcast to help you implement this content. Now, getting back to the point, we want the weight to go from the heel at the bottom of the squat to then go towards the midfoot and forefoot. If we get the weight forward to midfoot and forefoot, we're going to stimulate medial hamstring proximal gastro more, which is designed to delay knee extension. We delay knee extension, then the hip can do more active work so that the knee isn't doing the majority of the work. Okay, so the test we're going to use is we're going to use an outer range bridge essentially. Okay, so what I want you to do is you're going to be lying on your back. We're going to get the person to bring their foot out as far as they can while still maintaining plantar flexion. Now, this test, complete disclaimer before the keyboard warriors come at me, which, there's always someone looking to, look at every single little word you're saying and try and knock you down. So, complete disclaimer here. This clinical test, okay, it helps me give an insight, a working hypothesis. I'm not trying to make a diagnosis based on this test. I'm not trying to, say this is going to fix the world. What I'm trying to do is I'm trying to get the information that I've had from my subjective assessment and objective, and this is just one more test on that. Okay, in episode 2, we talked a lot about the linking the subjective to the objective assessment and the good information we're getting there. This is just an add-on to that. Okay, so if you just forget everything that you've been doing and you just use this one test and you put all your eggs in one basket based on this one test, you're probably not going to get great results. What this test is going to allow you to do, it's going to give you a snapshot into the strategies that the person's using currently. But as well, it's going to give me a snapshot into the load tolerance that the hamstring and the gastro can tolerate at this time before I get the patient to standing. So this is a useful test for me before the patient gets to standing. And what a lot of people on my return to play courses and my mentorship find is that a lot of people can't pass these tests, but we're doing a lot of work with them in standing where we're expecting the hamstring and gastro, especially high level hopping, high level sprinting, the hamstring and gastro are going to have to tolerate even more load than we're using with this test. So the test is lie on your back as if you're about to do a glute bridge, but I want that knee to extend quite a bit. Okay, and what I'm trying to do here is I'm trying to get the knee to an angle that's somewhat close to that kind of 15-20 degrees of flexion when the foot hits the floor in sprinting. Now, I appreciate we're never going to get that because we're going to be limited here by end range plantar flexion of the ankle. Okay, so what we need to do with this test for your patient is we need to find just the point where they can get full plantar flexion, the full foot's on the floor, and they have an ability to push through that midfoot and forefoot. If you take them a little bit further to complete end range and you get them to push through the midfoot or forefoot, they're probably going to get an ankle impingement in the back. Okay, we wouldn't want that. So again, this is the first bit of the test, which is interesting. You get them to go into that position, you get them to push through the midfoot, forefoot, and you ask them what they feel. Okay, some people when you get them to do that, they're going to subconsciously bring the heel closer to the bum. Okay, so what that tells me is that length tension relationship, they're trying to subconsciously protect the hamstring and gastro already. They're not happy to produce force at that length tension relationship. Now, what we want to do is we want them to push through the foot. We want to say, okay, what do you feel there? Where do you feel it? Okay, now for some people, they'll say, oh, I can feel my hamstring cramping, or some people I can feel it all in my calf. Well, we're wanting ideally is when they push through that midfoot is they want to feel it nowhere in particular. They want to feel in the gastro, the hamstring, and a little bit through the glute. When they push through that midfoot, we're looking to see does their hip react? Do we actually notice that the pelvis moves a little bit because we're getting a reaction at the hip through the foot? Okay, so again, when that foot is to the floor, we want that hip to be reacting with the foot. Now, here's where it gets interesting. That's just the start, okay? What I want you to do with the patient is I want you to get them to do a small little bridge, and I just want, and I mean an inch or two off the bed. I just want you to push through the foot, lift their bum off the bed a little bit. Now, they can have weight on the heel of the bridge if they want at this point, okay? And then all I'm going to get you to do is get them to get their weight consciously off the heel onto the midfoot and forefoot and just wait. Okay, so again, what everyone's going to do is when they try bridge up, is they're going to try bridge up to a full hip extension. They're going to arch their back. They're going to lift their back off the bed a lot. The lower the back is to the bed, the lower the hip is to the bed, the more load's going through the limb and not the lower back. Okay, a lot of people are going to want to get the back up because it's an easier test. What we are interested in with this test is, can you tolerate load through that limb before I get you into standing? Okay, so I'm going to push through I'm going to do a small little bridge. They're going to lift their bum a bit, and then I'm going to get them to get their weight off their heel, from their heel onto their midfoot, forefoot. I'm going to wait, and I'm going to time them. Okay, now what I'm looking for with kind of higher level athletes, I want at least 30 seconds. For your kind of sedentary, older population, we may want 6 seconds. Okay, I'm not interested in getting this test, published in terms of renaming it and all this stuff. It's just a snapshot. Okay, it's a clinical reasoning movement rather than some big test that's going to be massively reproducible, because everyone's ankle range is going to be slightly different. Everyone's going to have different kind of outcomes to this test. Okay, so what I want to do, I want to bridge up a little bit, an inch, so literally you can get a couple of credit cards under their bum there. That's going to mean all or a vast majority of load is going to go through the lower limb. Then I said it can be on their heel at that point. Then I just want them to shift the weight from the heel onto the midfoot, forefoot, and I want you to wait and see where they feel it. I want you to ask them the question where they feel that. And usually, ideally what we're looking for is I can feel my hamstring, my calf, my glute working. What you're going to find a lot there is you're going to get a lot of hamstring cramping. Okay, if we get hamstring cramping, then that's a big warning sign to me. Okay, or what you'll hear someone say is, oh, I can really feel my calf or my foot working here. Okay, if we feel a lot of calf and they're not feeling a lot of hamstring, then my next question there is, well, are they protecting the hamstring a little bit still here? Okay, so there's kind of two kind of thought processes to this. You might get someone, well, there's actually three usually outcomes, but again, if you have something else, that wouldn't necessarily surprise me either. But the first one is they're going to be able to do it and they're going to feel a lot of hamstring, a lot of calf, and they may then eventually, once that hamstring and calf are getting good at working isometrically, they may feel a glute start to burn a little bit as well, especially when they get on that midfoot, forefoot. The next person might do it and their hamstring will cramp straight away, which I would interpret that as a perceived threat, because again, they haven't been out conditioning. Okay, it's not a lactate acid buildup. I think that's a threat response. Okay, that cramping is just simply a threat response that the brain isn't happy for us to tolerate that high level of load through the hamstring. How I would respond to that, I would go straight to soft tissue desensitization techniques. That's just me. I'm going to talk a lot more about how my hands-on treatment complements my graded exposure program rather than just being passive. Okay, and that's going to be a podcast episode for another time. Or the other thing is they may not feel their hamstring at all. They'll feel it working a lot in their calf. But the second you get them off their heel, you're going to see a massive change in the distal hamstring, proximal gastro, because you're going to get a lot of more plantar flexion. And then we're going to see if they can work those two tissues together without cramping. So if someone's cramping at this level, what I see usually with a lot of my co-contraction based kind of higher level standing rehab work that I'm going to do to train the need to co-contract while the hip extends, I see a lot of people then when we're trying to do that stuff, the knee snaps back. Because again, we just can't tolerate that loading, where when I get someone in standing, I'm pretty much putting all their body weight on that leg. There's ways we can do that, which we'll talk about in other episodes. very easily. But when they go to hip extend, the knee will snap back. So again, the calf and the hamstring aren't able to tolerate enough load, enough body weight to delay any extension. So we see the knee snap back again. So this test for me, if we get this clean, so to speak, where we can bridge, we can hold it for about 30 seconds without cramping, then that gives me a lot of confidence then that hamstring and gastro are able to tolerate a bit of load, and now I can get them into standing. So I hope that makes sense. So it's a step-by-step process for me. You'll probably be sick of me hearing me say step-by-step system by now. I don't blame you. But that allows me to progress to the next step. So what we might do, okay, with someone that has an issue, is if you're effective with your desensitization techniques, hands-on or whatever you use. If you don't use hands-on, use whatever, tools or strategies, whatever you want to call them. I don't really care, if I'm being honest, what you call them, to get that person to the next level. So my hands-on treatment, it's designed to enable me to get to the next progressive loading stage. It's not to just rub somebody for the sake of it, or break up scar tissue or anything like that. It's just to desensitize the tissue to tolerate some level of load, and I'm going to put a bit of load through that with my hand. Now, if you're effective with your hands-on treatment, you should be able to clear this kind of protective response pretty quickly. I'll do probably 20 seconds of that, then I'll put them on their back. I'll do a little bit of that test again, but that then becomes an exercise. I'll get them breathing to desensitize the nervous system. Then I might put them back on the front again. I'll do another bit of hands-on and vice versa until we can clear that. And if you're good with your hands, you understand what you're doing, you can clear this test very, very quickly. Okay. Then when I have that cleared, then we'll go on to standing. So that gives me a lot of confidence then that when we get them to standing, we can actually get that hamstring and gastro tolerating a bit more load, so that we can allow the hip to do work rather than the knee snapping back and the person not feeling it in their hamstring and glutes. They're feeling it all in their quad and their deep calf or their iliacus. Hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit the go2physio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the Go-To Physio show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world. So the key thing I want you to take away today, this movement, you're going to get a lot of insights into the strategies that people are using now as a result of their previous injuries, their movement strategies that they use now. Ideally, we want the calf, the hamstring, the glute, the quad to do its job, nothing more, nothing less, in 3 planes of motion with all the different fibers. What this test will allow us to do is to highlight which parts or which areas of the body they have a conscious experience of maybe doing a little bit more work than others, okay? The ideal thing is we can bridge, we can hold it for 30 seconds, the bum doesn't come too high, and we check the other side, okay? You'll be surprised how many people with symptoms on their right side, for instance, and then you do it and they're actually okay, then you do it on the left, their hamstring starts cramping. So I hope now, after listening to my stuff for a little bit, you're starting to think, oh well, if the left side can't tolerate a lot of load, is it maybe the right side maybe doing a little bit too much more work, which is causing the symptoms to consciously manifest themselves? Again, we would have to link that to their injury history, and we would have to find that through a working hypothesis, through our objective assessment, rather than trying to make a claim based on this one test. Okay, I'm not saying for a second that this is the be-all and end-all test. Am I heck? All I'm saying to you is use this with your working hypothesis, and it'll give you a lot of valuable information about where maybe you need to start desensitizing and looking at, rather than trying to just isolate muscles. If you want another way to implement this, get the weight off the heel when you're doing your single leg bridges, okay? Do single leg bridges, but get weight through midfoot, forefoot, and the better your hamstring can tolerate that load, the better your hamstring can work to delay any extension, the more you're going to feel your glute. But not only that, you're going to feel your proximal glute. If you go from a sit to stand, you push through your heels, you're going to feel that your back's probably going to arch a bit. Okay, you do a sit to stand, you push through your midfoot. What you're going to feel is that instead of going vertical, you're going to go horizontal. You're actually going to feel yourself travel forward a little bit. You keep pushing through your midfoot, forefoot, you let your body weight go forward a little bit. As you keep pushing through your midfoot, forefoot, you let your hips go through a bit. Nice and slow. Push through the midfoot. As you come through your body weight, what you're going to find is that your proximal glute max is going to engage anyways. So you're never going to have to tell someone to squeeze their glutes at the top of the movement again. Okay, when I'm in gyms and I hear people say it, and I had someone today who was seeing another therapist who was saying, yeah, I'm squeezing my glutes all day. I'm just cringing. Okay, I'm respectful enough not to contradict and stuff like that, but at the same time, it's it winds me up, if I'm being honest with you. You should not have to squeeze your glutes. Okay, you should not have to pull your belly button in. Okay, if you're transverse abdominis, to have in your brain, should be able to do this subconsciously, but better still, a lot of this stuff, when you're sprinting in the real world, it's happening subconsciously, and it's happening not even at the brain higher center levels, it's happening at the spinal cord level. Okay, where that sensory information, it goes from the tissue to the spinal cord back again. Okay, so it doesn't even get to go up to the higher centers for a lot of this stuff. So I hope that's useful. I mean this respectfully. Okay, again, the last thing I want, and it's my pet hate when therapists trying to bag other therapists without understanding truly where they're coming from. Okay, I don't say it to be disrespectful, but as I said, I just want to hopefully stimulate some thought. When we bring it back to physiology, when we bring it back to muscle architecture, when we bring it back to basic physiology, we can see hopefully now that actually if we can get the person from the heel onto the midfoot, forefoot as the hip extends, then we're going to recruit everything rather than just trying to isolate one or two things. So that allows us to work smarter, not harder, and it can make a big difference for your patients. Okay, so what I need you to do now, especially if you're skeptical, if you think I'm an idiot and you don't like me, is I definitely need you to try it. Okay, please have the decency, the manners, if you want to call it that, to give it a try. See what you feel. Keep an open mind. That's all I ask. Okay, if you do, you don't like it, if it causes too much of a conflict for what you're teaching and what you're saying at the moment, that's fine. But I would encourage you to try it. Okay, so once again, thank you for your attention today. I appreciate your time, I appreciate your attention, I appreciate your interest in my work. I don't know it all, far from it. I'm like everyone else. I'm on my journey to clinical excellence. I'm trying to work smarter, not harder. I'm striving to help people get long-lasting results. I think that anyone can get someone out of pain quickly. I think the art of it is keeping the pain away. Okay, and taking someone through a graded exposure so that they build resilience and they can tolerate high levels of load without that pain experience coming back again. When stress, when life, when sleep gets in the way, real work gets in the way, that we can keep that pain away and we can make massive impacts on people's lives. That's what I'm about. As I said, I'm on my journey. I'm constantly evolving my own mentorship program. You'll see people who've gone from the 2015 mentorship to now. They are seeing a massive change in some of the techniques and the tools we're using. And that's a result of me learning from them, but it's also a result of me understanding physiology a bit better and starting to understand more and more deeply some of the stuff. Okay, again, my step-by-step graded exposure system, my thought process, my clinical reasoning, I'm doubtful that's going to change too much, but maybe the techniques, the exercises that we're using to get to the next level of graded exposure, then I think that that's probably going to evolve the more we understand this stuff and the more people are aware of it. Okay, so if you want more information about my book, about my mentorship, about other blogs, about other stuff or how we're implementing this, then please feel free to visit www.thegotophysio.com. And as I said, we've got loads of resources there. We've got a free download, the 6 steps I use for patient adherence, the checklist. And we've also got the Go-To Physio show and lots more content there to help you get real world results with real people and make long lasting impacts on their lives, because that's what I'm all about ultimately, is helping people get long lasting impacts. Okay, so thank you for joining me. I'll see you in the next show when we're going to shift gears again. The last couple of, this is one of the first episodes which is more clinical content. We're going to have lots more of these on the podcast as well. And as I said, it's going to be a mix between clinical content, critical thinking, strategy. Again, at the forefront of everything I do, it's to have confidence and clarity. That's phase one of my business growth plan. Therapist has to, in my opinion, have confidence and clarity of the problem and the solution after the initial assessment, or as close to that as they can, so that they can then effectively explain it to the patient, who then gets confidence and clarity, who gets buy-in, who stops them dropping off, who gets the result, who's happy, who gives word of mouth referrals, all of that stuff. Once we get all that stuff right, the business side of it takes care of itself. And then as the business grows, then that's where I think we definitely need then those business skills. Whereas I think a lot of therapists, we're not utilizing our clinic, or we're not maximizing our clinical skills enough to get the point across of how to build a profitable business ethically, with the forefront of it, the patient getting real world results. And I think if you're good at what you do, I think if you can get long-lasting results, I think if you show people you care, you're empathetic, you've got good communication skills, then I think you'll never be able to work as a therapist. Because a lot of people need our help, but they need our help the right way, in terms of it being all about them designing rehab programs specific to their needs, rather than, every back pain that comes in gets the same rehab, every knee pain gets the same rehab and treatment, no matter, their story. I think we need to design treatment plans specific to their needs. We need to build confidence and resilience for them. I think if we can do that, then we can help a lot of people out there. And I don't think you'll ever be able to work if you have those traits. Okay, so once again, enough babbling from me. I apologize. I'll speak to you soon, and I'll see you on the next episode. Hey, I hope you enjoyed today's show. For more information, please visit www.thegotophysio.com, where you can download my 6-step patient adherence checklist absolutely free, as well as read the accompanying blog that goes with today's episode. We've got lots of cheat sheets and clinical content to help you implement to get real world results with real patients, that ultimately helps you become the go-to therapist and allows you to build a profitable, busy private practice, or become that go-to therapist in professional sport. I'll speak to you soon on the next episode.